Welcome to the Radiographics Podcast. I'm Wendy Gibbs. As we're at the beginning of a new academic year, I was looking over the lists of top articles for trainees on the Radiographics website. Many are starting call, and you always want to know how to identify the worst injuries, especially when they can be subtle and the consequence of not finding them is patient disability or death. Cervical cerebrovascular injuries fit this category. They might not be suspected clinically, and the imaging findings may not be dramatic. So I'm going to summarize a great older, meaning 2018, article called Imaging and Management of Blunt Cerebrovascular Injury. This was so well written and has great images. I'm really glad I reviewed it. Blunt cerebrovascular injury, which I will call BCVI, is a relatively rare but potentially devastating injury in patients with high energy blunt force or direct cervical or craniofacial trauma. The radiologist plays an essential role in identifying and grading the various types of vascular injury, including minimal intimal injury, dissection with raised intimal flaps or intraluminal thrombus, intramural hematoma, pseudoaneurysm, occlusion, transection, and arteriovenous fistula. Early identification of BCVI is important as treatment with antithrombotic therapy has been shown to reduce the incidence of post-injury ischemic stroke. Screening is appropriate and cost-effective in patients with specific mechanisms of injury, particular imaging findings, and certain clinical signs and symptoms. Although digital subtraction angiography was previously considered the standard examination for screening, technological improvements have led to its replacement with CTA. MRA with vessel wall imaging holds promise as a supplemental imaging tool that may improve diagnostic specificity for vessel wall injuries. Understanding the screening criteria, imaging modalities of choice, imaging appearances, and grading of BCVI is essential for the radiologist to ensure fast and appropriate diagnosis and treatment. Historically, the true prevalence of BCVI has been difficult to ascertain, as many of these lesions are clinically asymptomatic at the time of initial imaging workup, overshadowed by more severe traumatic injuries, or masked by traumatic brain injuries. When left untreated, BCVI is associated with increased morbidity and mortality, most commonly due to stroke. The increases in morbidity and mortality are dependent on both the location and severity. Carotid artery injuries carry higher rates of downstream infarction than vertebral artery injuries, and higher grade injuries carry higher rates than lower grade, and that makes sense. Published data suggests that untreated blunt carotid artery injuries possess a morbidity rate of up to 67% and a mortality rate of almost 40%. Untreated blunt vertebral artery injuries have a morbidity rate up to 24% and a mortality rate up to 18%. Trauma is the most common cause of BCVI. High-speed motor vehicle collisions account for more than 50%. Other injury mechanisms include falls from heights greater than standing, pedestrian versus car accidents, assaults, suicide attempts that involve hanging, and other direct head, neck, and facial trauma. On rare occasions, cervical arterial injuries can be seen in the context of low injury mechanisms. A classic example of a trivial trauma mechanism is chiropractic manipulation of the neck. Patients with these injuries characteristically present with neck pain or vague neurologic complaints before being diagnosed with underlying cerebrovascular injury. Non-traumatic spontaneous cerebrovascular injuries have also been reported in mechanisms that would not typically raise suspicion for injury, including certain athletic activities and yoga positions, daily activities including coughing, nose blowing, shaving, and vomiting, and other activities that include rapid head movement. That should make us all nervous, I guess. Cervical spine fractures have the strongest association with BCVI, with injuries of the upper cervical spine, ligamentous injuries, and traumatic subluxations placing patients at the highest risk. In addition to cervical spine injuries, complex skull fractures, basilar skull fractures, occipital condyle fractures, displaced midface and mandible fractures, particularly those involving the mandibular condyles, are associated with BCVI. During blunt force head and neck trauma, the arteries of the neck may experience longitudinal stretching, twisting, or compressive forces. For carotid artery injury, it's thought that cervical hyperextension and contralateral rotation lead to stretching of the internal carotid artery over the C1 through C3 transverse processes, precipitating a vessel wall injury. In the case of vertebral artery injury, bone fracture, subluxation, or ligamentous injury may cause stretching of the vertebral artery between adjacent structures of the cervical spine or at the dural margins as the artery enters the skull. In addition to stretching and twisting injuries, direct blows to the neck may directly injure or compress an artery against an adjacent osseous structure. This may be seen when a steering wheel impacts an unrestrained driver's upper thorax or neck, or when a compressive force is applied to the neck, as in cases of strangulation. Such episodes of vascular impingement are also seen with cervical hyperflexion injuries and displaced mandibular fractures, where the ICA is crushed between the mandible and the spine. In the setting of BCVI, pathologic stretching, twisting, or shearing forces most commonly result in an intimal injury to the vessel, regardless of the mechanism. Blood flowing through the vessel lumen may then dissect into the vessel wall at the site of an intimal defect. This dissection can then propagate cranially in the direction of bulk intravascular blood flow. If severe enough, a vessel wall dissection may lead to substantial flow-limiting luminal stenosis or occlusion. Importantly, intimal injuries expose intravascular blood to the thrombogenic subendothelial extracellular matrix, leading to platelet activation, aggregation, and subsequent downstream embolization with vascular occlusion. Adventitial medial or adventitial injuries are distinct from the intimal injuries in that the intimal surface may remain intact. Instead of intravascular blood dissecting into the arterial wall through an intimal defect, an intramural hematoma forms within the vessel wall as a result of injury to the vasa vasorum. Blood then dissects through the media and/or adventitia, leaving the intimal lining of the vessel intact. Like arterial intimal injuries, dissecting intramural hematomas may cause luminal stenosis and/or occlusion, depending on the size and extent of the hematoma. A traumatic pseudoaneurysm is a focal outpouching of an arterial wall, in which all the layers of the vessel wall do not remain intact. Blood dissects through a breach in the vessel wall but is contained by incomplete mural layers, at minimum by adventitia or surrounding perivascular soft tissue. This results in a saccular or fusiform outpouching seen on vascular imaging. Like dissecting arterial intimal injuries and dissecting wall hematomas, pseudoaneurysms may also cause vessel stenosis and/or occlusion, as the aneurysmal pouch may compress the adjacent lumen. Additionally, abnormal flow dynamics within the aneurysm, in conjunction with exposed subendothelial materials within the sac, may promote blood coagulation, thrombus formation, and downstream clot embolization. Arterial transection is the most severe form of BCVI. These injuries produce arterial hemorrhage into the soft tissues of the neck or face and can result in massive stroke or rapid exsanguination. In some instances, a fistulous connection may form between the injured cervical artery and adjacent venous structures, resulting in a high-flow arteriovenous fistula. Carotid cavernous fistulas represent a specific form of AVF that may be seen in cases of traumatic skull base fracture or ruptured cavernous ICA injury, characterized by an abnormal communication between the internal carotid circulation and the cavernous sinus. So what are the clinical manifestations? These are highly variable, depending on both the artery injured and the vascular distribution affected within the brain. In the special case of carotid cavernous fistulas, symptoms may also include pulsatile exophthalmos, conjunctival chemosis, tinnitus, and cranial nerve palsies. Venous congestion from the high-flow communication results in orbital symptoms that can rapidly progress to vision loss. Notably, in as many as 80% of patients with BCVI, there's a latent period of variable length between the time of injury and when neurologic symptoms begin to manifest. This latent period may last anywhere from hours to days or longer. However, on average, it lasts approximately 72 hours before the onset of clinically identifiable infarction. It's during this latent period that vascular imaging is of highest value in terms of identifying symptomatic BCVI and guiding clinical management decisions. There's a wide spectrum of BCVI severity, and accurate radiologic grading plays an essential role in the clinical prognostication and management of these injuries. Over the years, multiple grading systems for evaluating the severity of BCVI have been developed and clinically tested. The Denver scale, which is also called the Biffle scale, is a widely accepted and commonly used system that assigns a grade to a lesion on a 1 to 5 point scale, with increasing grades corresponding to more severe vascular injuries. Grade 1 injury is a vessel wall irregularity, dissection, or intramural hematoma with less than 25% stenosis. Grade 2 injury is either a dissection or intramural hematoma with greater than 25% stenosis, but less than complete occlusion. or any injury demonstrating a raised intimal flap or distinct intraluminal thrombus. Grade 3 injury corresponds to a traumatic pseudoaneurysm. Grade 4 injury represents complete vessel occlusion. And grade 5 injury is defined as arterial transection and/or AV fistula formation. Take a look at the paper online to see the great examples of each of these. How about mimics and pitfalls? Differentiating BCVI from other non-traumatic vascular causes and normal vascular variants can be difficult. Understanding the findings of alternate diagnoses that mimic BCVI and the imaging pitfalls that prevent its visualization and identification are important to ensure an accurate and timely diagnosis and prevent a wrong diagnosis and inappropriate treatment. Atherosclerosis is extremely common and can be confused with BCVI. As atherosclerosis is more common in older patients, age and the presence of multiple vascular risk factors are useful pieces of clinical information to differentiate atherosclerosis from BCVI. The presence of calcification and lesion location at the common carotid artery origin, vertebral artery origin, or within the carotid bulb are suggestive of atherosclerosis. Vessel wall MRI with a fat-saturated T1 weighted sequence can help differentiate atherosclerotic plaque from an acute injury. In the case of BCVI, intramural hematoma may be bright on T1 weighted images, whereas atherosclerosis usually will not be. In addition to atherosclerosis, carotid fibromuscular dysplasia and vasospasm are relatively common. In the case of carotid fibromuscular dysplasia, the carotid arteries may demonstrate a string of beads appearance with alternating segments of vessel stenosis and dilatation. Multifocal and bilateral vascular involvement, as well as involvement of the renal arteries, are suggestive of FMD. Vasospasm is commonly encountered after severe trauma. It may be impossible to distinguish transient vasospasm from low-grade BCVI on initial cross-sectional imaging. Repeat imaging often allows distinction of vasospasm from BCVI, with vasospasm resolving over hours and BCVI usually lasting longer or even persisting indefinitely. Imaging artifacts are another common pitfall. This is particularly true when the vessels course behind the mandibles and enter the skull base. Motion can both obscure disease and/or create the illusion of it. Step-off artifacts may falsely create irregular luminal margins. Streak artifact from dental amalgam or spinal hardware is a common problem. Unfortunately, streak artifacts from dental amalgam occur at sites commonly affected by BCVI, the skull base and posterior to the mandible, and may either obscure or create the illusion of vascular injury. Poor arterial enhancement due to suboptimal bolus timing and venous contamination can obscure critical vascular findings, producing poor arterial opacification or allowing for confounding opacification of venous structures surrounding the vertebral arteries in the transverse foramina. In general, follow-up imaging is used to guide antithrombotic treatment decisions. CT angiography is the preferred follow-up imaging modality, given that it is fast, non-invasive, and cost-effective. It's been proposed that repeat CTA be performed 7 to 10 days following initial identification of grade 1 through 3 BCVI to evaluate for injury progression or resolution. Injury evolution is largely dependent on the initial injury grade. As a general rule, low-grade injuries, grade 1 or 2, are more likely to heal or improve than the higher-grade injuries. Up to 75% of grade 1 injuries will heal over the course of weeks to months. For grade 2 injuries, 8% will completely resolve and 30% will improve to grade 1 in the same time frame. Injury progression is highly unlikely for grade 1 injuries, but more common for grade 2 injuries, with 40% showing interval progression in grade at follow-up CTA. While grade 3 injuries heal or improve only 11% of the time, they worsen approximately 25% of the time. Up to 40% of grade 4 BCVIs recanalize. In all instances, injury progression to complete occlusion or pseudoaneurysm should prompt strong consideration for endovascular or surgical intervention. As an advanced imaging technique, vessel wall MR imaging supplements luminal time-of-flight MR angiography and represents a useful follow-up imaging exam for problem-solving vascular findings, including differentiating intraluminal thrombus from intramural hematoma, atherosclerotic plaque, or normal vessel wall. Studies have demonstrated that vessel wall MR imaging is feasible and superior to conventional MR imaging for detection of arterial dissection. Vessel wall imaging may be most useful in re-evaluating patients who have undergone recent cross-sectional imaging studies with equivocal results for the presence of BCVI. In these patients, vessel wall imaging often effectively allows BCVI to be ruled out or ruled in. Additionally, the ability of vessel wall imaging to demonstrate subtle vascular injuries is supported by recent research demonstrating its superior ability to allow identification of intimal flaps, vascular wall thickening, and intramural hematoma. There's a lot more in this paper, but I have to conclude here. Early identification of BCVI in trauma patients is essential for reducing injury-associated morbidity and mortality, with CTA serving as an effective BCVI screening test in patients who demonstrate specific clinical signs and imaging risk factors. In patients with BCVI, treatment with antithrombotic therapy is the standard of care, reducing the incidence of post-injury ischemic stroke and death. Follow-up imaging further guides treatment decisions, with lesion resolution serving as an indication to discontinue antithrombotic therapy, and lesion worsening suggesting a consideration of interventional therapies. Although CTA plays a central role in evaluating BCVI, new techniques including vessel wall MR imaging hold promise as supplemental imaging studies that may improve diagnostic specificity for vessel wall injury and decrease radiation exposure for these patients who are often young. The radiologist plays an essential role in identifying and grading BCVI, as well as interpreting results of follow-up imaging studies, and thus guiding subsequent treatment. All right, that's it for this week's podcast. Like I said, take a look at this one for the great figures and image examples. Also, you can find a number of top 10 lists for trainees and radiologists of all levels on the website. Many great resources there.